Welcome to the deep dive. Today, we're tackling a really serious and very time-sensitive medical issue, acute limb ischemia or ALI.
Yeah, it's a critical one.
Imagine the blood flow to your leg just suddenly slams to a near halt. That's basically ALI, and the stakes are incredibly high. I mean, even with all our modern medicine, something like 15% of people facing ALI still need an amputation.
It's a stark number, and the mortality rate within a year is also significant, around 15 to 20%.
Right. It really underscores how vital quick, effective treatment is.
Absolutely. It highlights the urgency and, well, the real challenges in managing this condition effectively.
So our mission today is to kind of cut through the complexity and really get a handle on the main surgical and endovascular treatments for ALI.
Okay.
We're using Rutherford's Vascular Surgery and Endovascular Therapy 10th edition as our main guide here.
Yeah.
So think of this as, getting the core knowledge on how doctors approach this from the initial diagnosis right through the different strategies they might use.
Sounds good. Let's dive in.
Okay, let's get into it. First things first, those initial moments after someone presents with suspected ALI. What happens right away?
Well, those first moments are absolutely vital. The immediate need is to figure out just how bad the blood flow loss is. That classification really dictates everything that follows.
Right. So step one, what are the absolute first moves?
First thing, you absolutely have to start systemic anticoagulation, basically aggressively thinning the blood.
Okay.
The standard is unfractionated heparin. Usually it's a quick initial dose based on the patient's weight, then immediately followed by a continuous IV drip.
And why the big rush to thin the blood? What's the main goal there?
The primary goal really is to keep those smaller blood vessels further down the leg open, and also to stop any more clots forming or, the existing one getting bigger. We're trying to preserve whatever flow is left.
Makes sense.
And that heparin infusion needs careful watching. Regular blood tests like APTT or anti-factor Z to make sure the dose is just right. Effective but not causing major bleeding.
And if someone's allergic to heparin?
Yeah, good point. For heparin allergies, there are alternatives. Direct thrombin inhibitors are the main ones used instead.
Got it. So immediate blood thinning is job one. What else is happening concurrently? Thinking labs here.
Right, labs are crucial. A whole battery of tests, really. You need a complete blood count, coagulation studies to check clotting, a metabolic panel to see how the organs are doing.
Okay.
And definitely a baseline fibrinogen level. That's really important if you're considering thrombolysis using clot-busting drugs later on.
And blood type, I assume.
Oh, absolutely. Blood type and cross-matching, just in case a transfusion is needed during potential surgery.
Anything else on the lab front specific to these ALI situations?
Yes, definitely. If it's a recurrent event or if we just can't figure out why the artery blocked, we'll often do a hypercoagulability workup looking for underlying clotting disorders. An arterial blood gas helps understand the acid-base balance, which ischemia can throw off. And importantly, a baseline CPK level.
CPK. That's for muscle damage.
Exactly. It helps us monitor for potential muscle injury that can happen when blood flow returns that ischemia reperfusion injury we worry about.
Okay, pretty comprehensive initial workup.
Yeah.
And you mentioned classifying the severity. That sounds key. How's that done?
Yeah, it's absolutely fundamental. We use the Rutherford classification of acute limb ischemia. It's a kind of like a staging system.
Okay.
Think of it maybe like traffic lights for limb danger. Class 1 is viable, sort of green light-ish, concerning, but stable for now. Class 2 is threatened, definitely yellow, need to act fast. And Class 3 is irreversible. That's the red light, often too late to save the limb itself.
So that classification really drives the next steps, doesn't it?
It's the roadmap, absolutely guides the treatment decisions.
Okay, let's walk through that. Class 1, the viable limb. What does that look like and what's the general plan?
Right, Class 1. Here, there's no major loss of feeling or movement. You can still feel pulses sometimes, or at least detect flow with a Doppler. The foot's getting some blood flow, maybe through smaller collateral vessels.
So less immediate panic.
Exactly. Because the limb isn't in immediate danger of dying, we have a bit more breathing room. We can do more detailed diagnostic studies, optimize the patient's other medical issues, and really weigh the treatment options carefully.
And treatment-wise for Class 1?
Often we lean towards an endovascular first approach, going inside the vessel. Since the tissue is okay for now, it can usually handle the potentially slightly longer procedure time that endovascular might take compared to open surgery.
Okay, viable means assess, optimize, plan, often endovascular first. What about Class 2, the threatened limb? Sounds much more serious.
It is definitely more urgent. Class 2 means the limb is at serious risk. We need to restore blood flow promptly to save it.
And there are subcategories here.
Yes, it's split into IATI, which is marginally threatened, and IBEB, immediately threatened.
What's the key difference?
It really comes down to the severity of the nerve damage from the lack of blood. In IDI, you might have numbness, tingling, maybe some mild weakness, but generally motor function is intact. You can still move the foot. So for ISA, an endovascular first approach is, again, very often considered. The choice depends on, well, lots of things. What caused the blockage, patient's overall health, any previous procedures, the doctor's experience, and critically, is surgical backup readily available if needed?
Right, that backup is key.
Always.
And then class IVA immediately threatened. What's the play there?
IC is a true vascular emergency. Significant sensory loss, definite muscle weakness or paralysis. The ischemia is severe.
So speed is everything.
Speed is absolutely everything. We need to revascularize extremely quickly to have a chance at saving a functional limb. Historically, open surgery has been the standard here because it's often the fastest way to restore flow.
But endovascular isn't totally out?
Not totally, no. In centers with experienced teams, good imaging, maybe a hybrid operating room, rapid endovascular techniques like aspiration, thrombectomy, sucking the clot out, or maybe pharmacomechanical methods might be an option.
If the operator is skilled and fast.
Exactly. The key for trying endo first in IIB is having someone skilled in both open and endo, and the ability to convert to open surgery immediately if the endovascular approach isn't working quickly. Time is muscle and nerve.
And finally, class 3, irreversible.
Yeah.
Sounds grim.
It is, unfortunately. Class 3 means the lack of blood flow has gone on too long or was too severe. There's permanent nerve and muscle damage. The limb might be rigid, paralyzed, profoundly numb.
So revascularization isn't helpful then?
Generally, no. Trying to restore blood flow is unlikely to bring back function, and worse, it can cause serious systemic problems for the patient that reperfusion injury can be dangerous. So, sadly, primary amputation is usually the definitive and safest therapy.
Understanding the classification is clearly crucial. Let's shift to the treatments themselves. You said surgery is still very relevant. What are the main surgical approaches?
Oh, absolutely. Surgical revascularization is still a cornerstone, effective across the board, really. It's vital that vascular surgeons maintain strong, open surgical skills.
Why is that so important now, with all the endo options?
Because open surgery is needed as a primary therapy sometimes, especially in those IAB cases. It's also crucial for salvage when endovascular attempts fail or aren't enough, and for complex hybrid procedures where you combine both open and endo techniques.
Okay, so what are the workhorse surgical techniques here?
Well, a major one is catheter embolectomy or thrombectomy. The Fogarty catheter is the classic tool, been around for decades.
How does that work?
It's basically a thin, flexible tube with a small inflatable balloon on the end. The surgeon makes an incision in the artery above the blockage, passes the catheter down through the clot, inflates the balloon gently, and then pulls the catheter back, hopefully bringing the clot out with it.
And they can repeat that.
Yeah, several passes might be needed. The exact spot for the incision depends on where the blockage is located, groin for iliac or femoral clots, maybe further down the leg for popliteal or tibial issues.
And how do they know they got it all?
Good question. They look for good pulsatile inflow coming back from upstream and good back bleeding from downstream. Often they'll do an on-table angiogram injected dye and take an x-ray right there to confirm flow is restored and there are no residual clots or distal emboli.
Okay, embolectomy. You also mentioned arterial bypass. When does that come into play for ALI?
Bypass is usually considered more often when the simple thrombectomy doesn't fully clear things, or if an initial endovascular procedure fails and leads to worsening ischemia. It's also common in situations we call acute on chronic thrombosis.
Meaning a clot on top of existing disease.
Exactly. Someone with known peripheral artery disease gets a sudden acute clot. In those cases, a bypass might offer a more durable long-term solution than just removing the clot.
Is it the same kind of bypass as for chronic limb ischemia?
The principles are very similar, yes. You need imaging beforehand, CT or angiogram, to plan where to attach the bypass graft above and below the blockage. And you need to choose a conduit, usually the patient's own vein if possible, or sometimes a synthetic graft.
There was a study you mentioned looking at bypass specifically for ALI. What did that show?
Right. The Vascular Study Group of New England looked at this. They found that patients needing bypass for ALI were, well, often sicker to begin with. less likely to be on preventative meds like aspirin or statins, more often smokers, more likely to have had prior failed procedures on that leg.
So a tougher patient group.
Definitely. The bypass procedures themselves tended to be longer, involve more blood loss, more use of prosthetic grafts, and while the bypasses often stayed open okay at 1 year, the ALI group had significantly higher rates of major complications, limb loss, and mortality compared to patients getting bypassed for chronic disease.
What's the takeaway from that?
It really highlights that ALI often hits patients with advanced disease and multiple health problems. Even a technically successful bypass doesn't erase those underlying risks. It also suggests maybe outcomes are worse after a failed endovascular attempt, pushing people towards bypass in a more critical state. Poor risk factor control is a big issue too.
Okay. And briefly, thromboendarterectomy and hybrid procedures.
Thromboendarterectomy, surgically cleaning out plaque from inside the artery, isn't usually the main procedure for ALI by itself, but it can be very useful with other things, like cleaning up the inflow or outflow area for a bypass graft, or improving flow into important collateral vessels.
And hybrid.
Hybrid means combining open and endovascular steps in one operation. Really useful when, say, a previous endovascular stent has caused a problem leading to the acute ischemia. You might do an open procedure to remove the stent and clean out the artery, then maybe place a new stent endovascularly in a different area, all in the same go.
So pulling back a bit, what's the overall verdict on surgical revascularization outcomes for ALI?
Well, despite being effective tools, the long-term outcomes after surgery for ALI honestly remain somewhat poor. Studies consistently show higher 1-year limb loss, like over 20% in some series, and mortality rates around 15–20%, which is significantly worse than for elective bypass surgery.
Why is that, do you think?
It likely reflects the patient population, as we discussed advanced comorbidities. And also, these patients are just really susceptible to that ischemia-reperfusion injury cascade, which can have devastating systemic effects, even if the limb blood flow is restored. It's a tough challenge.
It's a very sobering reality.
Yeah.
Okay, let's pivot then to the endovascular side. These have become much more common, haven't they?
Hugely common, yes. Endovascular therapies have really changed the landscape. The goal is the same: clear the clot, restore flow quickly, but doing it from inside the vessel using catheters and specialized tools.
What are the main categories here?
You can broadly group them into 3 main types: catheter-directed thrombolysis, or CDT, where you infuse clot busters; then a pharmacomechanical thrombectomy, PMT, which combines drugs with mechanical removal; and finally, purely mechanical thrombectomy, MT, which uses devices to remove the clot without lytics.
What's seen as the big advantage of endo?
A major potential plus is that it's generally less invasive than open surgery. This can be a huge benefit for patients who are quite frail or have lots of other medical problems that make major surgery very risky.
That's another point you mentioned.
Right. If the ALI is due to acute on chronic disease, that clot forming on existing plaque, the endovascular approach often lets you see the underlying stenosis, the narrowing, after you clear the clot. And then you can potentially treat that lesion right then and there, maybe with angioplasty or a stent, or plan a targeted open repair later.
Okay, let's break those down. Starting with CDT, catheter-directed thrombolysis. How does that work?
So CDT involves threading a very thin catheter right to the blood clot, or sometimes through it. Then you slowly infuse a thrombolytic medication, a clot buster drug, directly into the thrombus itself.
Aiming it right at the target.
Exactly. Delivering it locally like that helps maximize the effect on the clot while minimizing the amount of drug circulating systemically, which hopefully reduces the risk of bleeding elsewhere in the body.
Who is CDT typically used for?
It's often a go-to for patients with less severe ischemia, so Rutherford class 1, or maybe IA. Particularly useful for relatively fresh clots in native arteries, bypass grafts, or even clotted stents. But, and this is crucial, you can't use it if the patient has a high risk of bleeding.
Right, you mentioned contraindications. Can you remind us of the main ones?
Sure, it's a pretty long list, but the big ones are active bleeding anywhere, recent stroke or brain spinal surgery or major head injury, recent major surgery or trauma, uncontrolled severe hypertension.
Okay.
Also things like recent CPR, if you had to puncture a vessel you can't compress, brain tumors, pregnancy, some specific eye conditions like diabetic retinopathy, severe liver failure, or endocarditis. Clinical judgment is key here, weighing the limb risk versus the bleeding risk.
It's a complex balance. So if CDT is chosen, how do they actually do it?
Technically, it starts with getting access into an artery, usually the femoral artery in the groin opposite to the affected leg. Ultrasound guidance is standard now for safe access. Then you use wires and catheters under X-ray guidance, fluoroscopy, to navigate up and over the aortic bifurcation and down towards the blockage in the affected leg. You do an angiogram, injecting contrast dye to see exactly where the clot starts and ends and what the vessels look like downstream.
Then what?
Once you decide on CDT, you usually give more heparin and then place a longer sheath, like a support catheter, often positioned over the aortic bifurcation. This gives you stable access.
Got it. Then you cross the clot.
Yep. The next step is carefully advancing a guide wire across the occlusion. Often a special slippery wire, maybe with a support catheter. There's even something called the guide wire traversal test. If you can cross easily, lysis might work better.
And once you're across?
You confirm you're in the true vessel lumen, maybe do another small angiogram distally. Then you swap out the support catheter for a specialized infusion catheter.
What's special about it?
These catheters have multiple side holes along a certain length. The idea is to position these holes spanning the entire clot, so the lytic drug gets distributed throughout the thrombus. Some, like the Unifuse catheter, even have features to help ensure even drug delivery.
Okay, catheters in place. What drug do you use and how?
In the U.S., the standard is recombinant tissue plasminogen activator, RTPA, brand name Alteplase. The typical approach is a low-dose continuous infusion. Maybe a small initial bolus dose right into the clot, then a slow drip like 1 milligram per hour, often overnight for 10-12 hours.
And you check progress.
Absolutely. Usually an interval angiogram the next day or sooner if the patient's condition changes. And throughout the infusion, very close monitoring of blood clotting parameters like fibrinogen levels every few hours. You might adjust the infusion rate or even stop it based on those labs.
And still need heparin?
Yes. Usually a low-dose heparin infusion runs concurrently through the side port of the main access sheath to prevent new clots from forming around the catheters themselves.
You mentioned trials comparing CDT to surgery. What were the main takeaways from those big studies like Rochester, Style, Topaz?
Yeah, those were landmark trials. The Rochester trial suggested maybe better overall survival with CDT, possibly fewer cardiopulmonary complications than surgery, but also higher bleeding risk with lysis. Importantly, it showed CDT was often an initial step. Many patients still needed surgery later.
Okay. And Style?
The Style trials were interesting. They found that for acute ischemia, less than 14 days, thrombolysis seemed better initially, lower amputation, better amputation-free survival at 6 months. But for more chronic ischemia, longer than 14 days, surgery seemed superior long-term, especially regarding freedom from recurrent ischemia or amputation. It also showed lysis could sometimes reduce the extent of surgery needed later.
So timing matters. What about Topaz?
Topaz used a different lytic, urokinase. It found similar limb salvage and survival compared to surgery for acute ischemia, but again highlighted the increased risk of major bleeding with thrombolysis, particularly when given with full-dose heparin.
So the overall message from these trials?
Kind of a mixed bag, but generally they supported CDT as a reasonable first-line option, especially for acute occlusions in certain patients, but underscored the bleeding risks and the fact that surgery often provides more durable long-term results, particularly for more chronic or complex situations. Patient selection is really key.
Okay, that covers CDT. Now, pharmacomechanical thrombectomy, PMT, you said it combines drugs and devices.
Exactly. PMT aims to speed things up and potentially reduce the total arolytic dose by using a mechanical device to help break up and remove the clot while also delivering some mucolytic medication directly into it.
How does that work in practice? Same setup?
Pretty much the same initial setup, yeah. Ultrasound-guided access, diagnostic angiogram, crossing the lesion with a wire. But then instead of just an infusion catheter, you bring in a PMT device.
Like the angiojet you mentioned.
Right. Angiojet is a well-known one. It uses high-velocity saline jets based on the Bernoulli principle to create a macerating effect on the clot and a vacuum to suck it out. Some versions can also do what's called power pulse spray.
What's that?
That's where you inject small, forceful pulses of a lytic drug mixed with saline directly into the clot. Let it dwell for maybe 15-20 minutes to soften things up, and then you switch to the thrombectomy mode to aspirate it.
Has that shown promise?
Yeah, studies like the Pearl Registry looked at angiojet PMT. They compared using it alone versus using it followed by standard CDT. The PMT alone group needed lower polytic doses, had shorter procedures, fewer sessions, and in matched groups, PMT alone actually had better procedural success and amputation-free survival at 1 year.
So potentially a faster single-session treatment.
That's the hope, yeah. especially for certain types of clots. Other studies comparing angiojet PMT to standard CDT found similar limb salvage and survival, maybe higher technical success with angiojet, but not always a huge difference in major outcomes.
Any other PMT devices work differently? You mentioned ECOS.
Right, the ECOS catheter is different. It's also an infusion catheter for ilex, but it has an ultrasonic core wire running through it.
Ultrasound, how does that help?
The theory is the ultrasound energy helps to drive the lytic drug deeper into the clot structure, making it work more efficiently. Studies suggested it could lead to faster lysis, maybe use less drug, higher technical success.
But did trials show better clinical outcomes?
Well, the DOT trial, a randomized study in the Netherlands, compared ECO's ultrasound-accelerated thrombolysis, UST, to standard CDT. It found faster lysis with less drug using ECOS, but no significant difference in technical success, limb salvage, bleeding, or patency at 30 days.
So faster maybe, but not necessarily better overall results.
That's what DOT suggested, and other retrospective reviews comparing ECOS to standard infusion catheters like Unifuse haven't consistently shown significant differences in major clinical outcomes either. So the jury's still kind of out on whether the added complexity and cost of ultrasound brings a definitive clinical benefit for most ALI cases compared to standard CDT or other PMT methods.
Okay, interesting. That brings us to the third category, purely mechanical thrombectomy, MT. No lytics at all here.
Correct. MT devices rely solely on mechanical forces, aspiration, rotation, fragmentation, to remove the thrombus without any thrombolytic drugs. This is obviously appealing for patients with high bleeding risk, where lytics are contraindicated.
What kinds of devices are we talking about?
There's quite a variety. A big category gaining popularity is aspiration mechanical thrombectomy, or AMT.
Like the Indigo system?
Exactly. The Indigo aspiration catheters, part of the Penumbra system, are essentially large bore catheters designed for powerful suction. You position the catheter tip right at or in the clot, connect it to a vacuum pump, and it aspirates the thrombus.
Does it work well for ALI?
It seems particularly good for fresh, soft thrombus and emboli. You can get different catheter sizes depending on the vessel diameter. Sometimes they have little separator wires you can pass through the catheter to help keep the tip clear if it gets clogged with clot.
What's the data like for AMT and ALI?
It's still emerging, honestly. Not a lot of large randomized trials specifically for ALI yet. But retrospective studies, like one from the Mayo Clinic using Indigo, showed decent technical success, around 50% as the only therapy needed, with very low rates of bleeding complications or distal embolization. Other single-center studies report similar findings, and they keep developing larger catheters for bigger vessels.
So promising, but needs more data. What about other mechanical approaches? You mentioned rotational devices.
Yeah, there are devices that use mechanical rotation or fragmentation to break up the clot, often combined with aspiration. Fewer of these are maybe used routinely first line for ALI compared to aspiration or PMT, but they have a role.
Like the Rotor XS.
Right, the Rotor XS is one example. It's designed to remove both acute clot and underlying chronic plaque. It has a rotating helix inside an outer catheter that spins at very high speeds, breaking up the material, which is then aspirated out.
And the results for Rotor XS in ALI.
Retrospective studies have reported pretty high procedural success rates, over 90% in some cases, although maybe needing additional procedures like angioplasty afterwards. Distal embolization risk seems relatively low.
Any prospective data?
Yes, there was a single-arm prospective trial looking at Rotor XS as the initial therapy for acute and subacute limb ischemia. Included over 200 ALI patients. Technical success, defined as less than 50% residual blockage with Rotor-X alone, was around 73%. But many needed adjunct procedures like angioplasty or stenting to get less than 30% residual stenosis.
How did it do long-term in that study?
The 30-day amputation-free survival was pretty good, around 94% for the ALI group, and 12-month AFS was about 87%. The reintervention rate within a year was around 15%. So the study suggested it's a potentially useful initial tool across different ALI severities and anatomies.
Okay, so we've covered surgery, CDT, PMT, MNT, lots of options. Stepping back, what's the big picture on outcomes for ALI in the modern era? With all these tools, are things getting better?
That's the million-dollar question, isn't it? We certainly have more tools, more ability to tailor treatment. Surveys show endovascular approaches are being used much more, especially for maybe less severe cases like Rutherford the Saya.
But are patients actually doing better overall?
Well, large database reviews looking at Medicare data or the VA system over many years have shown a concerning trend. Even though endovascular use went up, and overall ALI admissions maybe went down slightly. Risk-adjusted mortality and amputation-free survival rates haven't really improved much.
Really? despite all the tech.
Yeah. 1-year survival rates for ALI patients remain stubbornly poor, unfortunately, even in this endovascular era. Another analysis of the nationwide inpatient sample showed increased endovascular first approaches, but also rising costs and no significant improvement in limb salvage rates over a decade.
So what does that tell us?
It tells us that while we're good at the plumbing opening the vessel, the underlying patient factors, the systemic hit from ALI, are still major determinants of outcome. Meta-analyses comparing catheter-based therapies versus surgery generally find comparable limb salvage rates.
So, no clear winner overall.
No clear winner in terms of limb salvage or mortality in many comparisons. This equipoise means we really need to think hard about patient selection, procedural durability, cost-effectiveness, and long-term quality of life when choosing between open and endovascular approaches. It's not just about immediate technical success.
That makes sense. And after the procedure, whichever one is chosen, there are still risks, right?
Yeah.
You mentioned ischemia reperfusion injury.
Absolutely. Restoring blood flow is critical, but it's not without its own dangers. That sudden return of oxygenated blood to tissues that have been starved can trigger inflammation and release of damaging substances.
What are the main things to watch for post-procedure?
2 big ones are rhabdomyolysis and compartment syndrome.
Rhabdo, muscle breakdown.
Right. Damaged muscle releases myoglobin, which can clog up the kidneys and cause kidney failure. We monitor for this with urine tests and blood tests like CPK levels. Aggressive 5E fluids are key to help flush the kidneys.
And compartment syndrome.
This happens when swelling occurs within the tight muscle compartments of the lower leg after blood flow returns. The pressure builds up, cutting off blood flow again at a microvascular level, damaging muscles and nerves further.
How do you manage that?
Clinical suspicion is key: severe pain, tense swelling, pain with passive stretch of the foot. If suspected, we measure the pressures directly. If they're high, the treatment is urgent surgical fasciotomy, cutting open the tight fascial coverings of the muscle compartments to relieve the pressure.
Is that done often?
Prophylactic fasciotomy, doing it preventatively, is often considered if the ischemia was prolonged, say over 6 hours, or if there were significant motor deficits before revascularization. Delaying a needed fasciotomy dramatically increases the risk of amputation.
So managing ALI is challenging from start to finish.
It truly is. It remains one of the most clinically challenging areas in vascular medicine. We really need more high-quality randomized trials to help define the absolute best practices for clearing clots and restoring flow using all these different techniques we have now.
So, to wrap things up, we've definitely taken a deep dive into the pretty wide range of treatments for acute limb ischemia, from that crucial, immediate anticoagulation.
Through all the surgical options like embolectomy and bypass and the various endovascular strategies, CDT, PMT, MT.
Right. And it's clear the choice isn't simple. It depends heavily on the severity of the Rutherford class, but also the patient's overall health, what caused the blockage, and frankly, the expertise and resources available where they're being treated.
Exactly. It's a complex decision tree, always aiming for that critical goal: save the limb, and hopefully improve the patient's overall chance of survival and long-term function.
And despite all these options, the outcomes data tells us we still have a long way to go, highlighting just how serious ALI is.
Precisely. It remains a major challenge.
So here's a final thought for you, our listeners, to think about. We heard that recent data often shows comparable limb salvage rates between many surgical and endovascular approaches for ALI. If the immediate success in just saving the limb is often similar, what other factors do you think become most critical in determining a patient's long-term well-being after facing acute limb ischemia?
Good question.
Is it maybe about faster access to specialized centers, or the overall cost and resource use of different treatments? Or perhaps it comes down to the patient's quality of life, their functional recovery after these intensive interventions. Definitely something worth pondering as the field continues to evolve. Thanks for joining us on this deep dive.